I'm Dr. Fakir Rabari, and this is Pharmacokinetics and Pharmacodynamics of Aminoglycosides in adults. Our first learning objective is, given a patient with stable renal function, calculate estimated creatinine clearance using the Cockcroft-Gault equation. Because aminoglycosides are almost exclusively cleared renally, it is important to be able to assess renal function. Let's take a look at what happens in the nephron. Generally speaking, there are three things that happen: filtration, secretion, and reabsorption. Glomerular filtration is a passive process that occurs in the Bowman's capsule. During this process, water and small ions and molecules, including drugs, diffuse passively into the lumen. Secretion is an active process that occurs mostly in the proximal tubule. There are many transporters involved that secrete substances into the tubule. And finally, there is reabsorption, which is also an active process, and it mostly occurs in the distal tubule. The best way to assess renal function is to measure glomerular filtration rate, or GFR. Now, you can either measure GFR or you can estimate it using equations. Measure GFR is the best index of renal function. And when measuring GFR, we want to use a substance that is filtered only and is not secreted and it's not reabsorbed, because we are only measuring the filtration process. Inulin is a substance that's clinically available and is used primarily by nephrologists, but it's not routinely used in clinical practice because it's expensive and it's not readily available outside of nephrology. Therefore, oftentimes we have to estimate GFR, and there are equations that we can use, including MDRD and CKD-EPI. These equations are validated in patients with CKD specifically, and MDRD tends to underestimate GFR in general, so CKD-EPI happens to be a more accurate equation compared to MDRD. Another thing that we can do to assess renal function is to use creatinine clearance as an approximation of GFR. And just like GFR, when it comes to creatinine clearance, we can either measure it or we can estimate. The way that we measure creatinine clearance is by actually collecting urine. Typically, the best way to do it is to collect urine for a 24-hour period and then get a urine creatinine level as well as a serum creatinine level, and use this equation to get the actual creatinine clearance. As you can imagine, this process of collecting urine for 24 hours might not be practical. And if we collect urine for a shorter period of time, let's say over 4 hours, it becomes more practical, but it reduces accuracy. So another thing that we can do, we can actually estimate creatinine clearance using Cockcroft-Gault equation, which typically overestimates GFR. Again, creatinine clearance is only intended to approximate GFR, so it is not an actual GFR. Some limitations of creatinine is that creatinine, not only is it filtered, but it's also secreted and eliminated by gut bacteria. It depends on muscle mass, nutrition, age, and drug interactions, and it typically lags in the setting of acute renal change. So creatinine clearance can only be used in stable renal function. Here's how this equation was developed. In the 1970s, two colleagues, Cockcroft and Gault, did a study at the VA which included 96% male patients, and they did 24-hour urine collection, and from their data they derived an equation. And because most of their patients were male, they did a correction for deriving an equation in females. Again, avoid use of this equation in patients with unstable renal function. For example, if the patient has AKI, this equation is not valid, because in this study that they derived this equation, everybody had stable renal function. Although in the original equation they used the total body weight, it's been suggested that total body weight may not be the best estimation for every patient. So typically, we actually calculate ideal body weight, which are these equations. When it comes to patients who actually are less than 60 inches tall, it's suggested to use these numbers for ideal body weight. Of course, you should always use clinical judgment. One thing that I have seen clinicians do is, for example, if somebody's height is 58 inches, they would use a -2 in these equations to actually subtract. There are no universal guidelines on how to approach this in different patients, so you may work with different clinicians who approach this differently. For the purpose of this class, we will use these equations. You might wonder, what about patients who have had amputation? For those patients, you can actually use this chart in order to subtract from the ideal body weight whatever limb they're missing. For example, if somebody had below the knee amputation, you can actually subtract 6% of the ideal body weight that you calculate. These numbers are just for your reference, so you do not need to memorize these percentages for patients with amputation. For patients who are obese, and obese is defined as a BMI of greater than 30, or a total body weight that is about 20 to 30% over, or I should say at least 20 to 30% over ideal body weight. And the reason there is a range here is because different studies have used different cutoffs. So some studies have used 20 as the cutoff, and some studies have used 30. Again, there is no universal guideline on how to do this, but these are the ranges that are typically used in clinical practice. For the purpose of this class, we will not have a case that's in the middle of this, so you will either have a patient whose total body weight is more than 30% or less than 20%. And then for the actual equation to calculate adjusted body weight, there are different factors described in the literature. Again, for the purpose of this class, we're going to use the 40%. So we're going to use this equation in this class to calculate adjusted body weight. But I'm just showing you that there are other equations out there. So when you are on rotations, you may work with preceptors that may use different equations. So again, there is no universal guideline on what you should do. You should use your judgment. And for this class, we will use this equation. And of course, when it comes to bodybuilders, you know, even though their BMI may look like it's too high, or if their total body weight is more than 20 to 30%, that's typically their muscle. So you may not actually have to calculate adjusted body weight, but always use your clinical judgment. So going back to the Cockcroft-Gault equation, if someone is underweight, meaning that their total body weight is less than their ideal body weight, you should use total body weight in the Cockcroft-Gault equation. Someone who has a normal weight, meaning that they weigh at least their ideal body weight but less than 1.3 times the ideal body weight, you should use the ideal body weight in the Cockcroft-Gault equation. And of course, someone who's obese, and for the purpose of this class, we're going to use the cutoff of 1.3 times the ideal body weight. You should calculate the adjusted body weight and use the adjusted body weight in the Cockcroft-Gault equation. Now, these are for the purpose of this class. You know, there are no universal guidelines. So if you come with, you know, always follow what your preceptor tells you. And of course, beyond graduation, always use your own clinical judgment to decide what to do in your practice. And of course, there are clinicians who round serum creatinine of less than 1 to 1 in elderly. You know, a common thing that's out there is if a patient is 60 years old or older and serum creatinine is less than 1, I have seen clinicians round it to 1 just because elderly have less muscle. Because of less muscle, that serum creatinine might artificially be low. Now, in the literature, this is generally not recommended because you tend to underestimate creatinine clearance. So it is not recommended to round serum creatinine in elderly. Now, there are situations that you may need to round. So, and in the literature, it's recommended to round to 0.8. So if serum creatinine is less than 0.8, round it to 0.8. Not necessarily for elderly, but for malnourished, because serum creatinine comes from muscle. So if someone has low albumin or low protein, that could be an indicator of malnutrition. Or someone who just happens to have very low muscle mass, for example, or someone who's paraplegic. For those patients, you may round serum creatinine of less than 0.8 to 0.8, but still use your clinical judgment. We looked at estimating creatinine clearance using the Cockcroft-Gault equation. Now, the next learning objective is explain the mechanism of action and toxicodynamic properties of aminoglycosides. Most aminoglycosides are natural products that naturally exist in nature, and the naming of these aminoglycosides are actually based on the organism that they are derived from. So streptomycin, neomycin, and tobramycin are actually derived from Streptomyces species. We also have gentamicin, which is derived from Macromonospora species. We also have a couple of aminoglycosides, amikacin and plazomicin, that are semi-synthetic derivatives. So these are actually developed in the lab. Aminoglycosides are available as IV formulation, with the exception of neomycin, which is available as PO, and there is also a cream formulation. Aminoglycosides have concentration-dependent rapid bactericidal activity against gram-negative organisms. They inhibit protein synthesis by primarily binding to the 30S subunit of the ribosome. In this picture, we're looking at a typical bacterial cell. You can see that inside the cell there is a circular chromosome along with multiple plasmids. There are also multiple ribosomes. In prokaryotes, we have 70S ribosomes. So all of these 70S ribosomes are floating inside the cytoplasm. Now, the 70S ribosome is the primary site of action of aminoglycosides. The 70S ribosome consists of a 50S subunit along with a 30S subunit. Aminoglycosides in particular bind to the 30S subunit. The function of the ribosome is to translate messenger RNA into a polypeptide. So these amino acids will come into the ribosome and, based on the genetic code, form a polypeptide chain. An aminoglycoside will interrupt this translation process. Now, note that ribosomes are inside the cell, and in order for aminoglycoside to work, they actually need to go inside the cell first and then find this ribosome and inhibit protein synthesis. In this picture, we're looking at the cell wall of gram-positive and gram-negative bacteria. The primary difference between gram-positive and gram-negative organisms is the outer membrane that exists in gram-negative organisms. So there are two layers in gram-negative cell wall. There is the plasma membrane, followed by a tiny layer of peptidoglycan, and then the outer membrane. Gram-positive organisms, on the other hand, they have the plasma membrane, followed by a thick layer of peptidoglycans. And there is no outer membrane. And because there is no outer membrane, this peptidoglycan layer can actually grow and get thicker. The reason this is significant is because aminoglycosides are polar and they cannot penetrate through the peptidoglycan layer. In order for them to get inside the cell down here, they actually need to use either porine channels or use carrier proteins. In other words, aminoglycosides cannot simply penetrate through these layers. Therefore, aminoglycosides are active primarily against gram-negative organisms because they can go through these porine channels, and there is a tiny layer of peptidoglycan that they can go through, and then they can go through more porins and get inside the cell where the ribosomes are. When it comes to gram-positives, because aminoglycoside cannot get through peptidoglycan, they do not have activity against gram-positive organisms on their own. However, we can use aminoglycoside for synergy with other antibiotics, and those other antibiotics typically are active against peptidoglycan layers. So if the other antibiotic will break down this peptidoglycan layer, then and only then aminoglycoside can get inside the cell and act on ribosomes and give synergistic effect with the other antibiotic. Now, when we look in more details of what happens when aminoglycosides bind to the 30S subunit of the ribosome, you can see that the first thing is that they block initiation of protein synthesis. And if protein synthesis has already initiated, they can block further translation and actually cause premature termination of translation. They can also cause incorporation of incorrect amino acids into the protein product. Now, when it comes to the spectrum of activity of aminoglycosides, and this is in general for all aminoglycosides, for gram-positives, it is essentially synergistic activity. So especially for enterococci, for some infections such as endocarditis, they are used for synergistic activity with other antibiotics, specifically with beta-lactams. The same for Staphylococcus aureus. But their true activity is really in gram-negative arena. So H for Haemophilus influenzae, so they have great activity. For protease, E. coli, and Klebsiella, and of course for Capes organisms, and that's in general. So Citrobacter, Acinetobacter providentia, Enterobacter serratia. Now some of these can develop resistance, for example Acinetobacter, but there's a good chance that aminoglycosides will be active against these organisms. Now with Pseudomonas, I have put a plus minus because really the anti-pseudomonal aminoglycosides is tobramycin and plazomycin, and I'll talk more details about the anti-pseudomonal activity of aminoglycosides shortly. And they do not have activity against any anaerobes or atypical bacteria. Now in 2023, CLSI breakpoints updated. So prior to 2023, in up to 2022, there were breakpoints for susceptible, intermediate, and resistant for Enterobacterialis and Pseudomonas. What happens in 2023 was that because these breakpoints were pretty old, so they've been around since 1980s, and they hadn't been really updated, and we know much more about pharmacokinetics and pharmacodynamics of these agents nowadays. So the committee updated. So what they did is that they actually lowered the breakpoints for Enterobacterialis. So previously an MIC of 4 or less was considered susceptible for gentamicin and tobramycin. That has been lowered to less than or equal to 2. And this is assuming, the most common dosing nowadays is 7 milligram per kilo once a day. And this regimen is really designed to get an MIC of around 2, or I should say concentration of around 2. So an MIC of 2 or less was decided, based on many factors, including the dosing we use and the pharmacokinetics and pharmacodynamics, as well as clinical studies that are out there. Now for amikacin, the susceptible breakpoint was less than or equal to 16, and it is now less than or equal to 4, and that's based on 15 milligram per kilo once a day. Plazomycin, which is the newest aminoglycoside, came to the market in 2018. Previously, we did not have CLSI breakpoints for them. So now there are added, so less than or equal to 2 is considered susceptible for plazomycin. And this is for all types of infections. Now, with regards to Pseudomonas aeruginosa, previously, we had susceptibility breakpoints for gentamicin, tobramycin, and amikacin. What happened in 2023 is that gentamicin, given the distribution of MICs among Pseudomonas isolates and the PK/PD of gentamicin, it is no longer considered active against Pseudomonas. So in fact, there are no criteria for susceptibility for gentamicin in regards to Pseudomonas. So it was actually removed. In other words, if there is a sample sent to the micro lab, they should not be testing it against gentamicin. So you should just consider that resistant. They will not be testing to report it as either susceptible, intermediate, or resistant, because it will just not be susceptible. So we should just consider resistant. For tobramycin, the breakpoint was reduced from less than or equal to 4 to less than or equal to 1, and that is based on the dose that we can use safely in patients, because if we increase the dose, we can cause unnecessary toxicity. And with amikacin, it has remained the same. The only thing that has changed is that this is only good if you are using it for a urinary tract infection. So if you have Pseudomonas in the urine, we're going to get, using 15 milligram per kilo once a day dosing, we're going to get enough concentrations in the urine, but not anywhere else in the body. So for any systemic infection, amikacin is no longer considered active against Pseudomonas. And with plazomycin, which is again the newest agent, we didn't have susceptibility breakpoints before, and we still don't. So for Pseudomonas, we still don't have criteria for plazomycin. Now let's take a look at toxicodynamic properties of aminoglycosides. So as we discussed, aminoglycosides bind to the 30S subunit of the ribosome and inhibit protein synthesis, and this can also happen in mitochondria, so it can lead to mitochondrial toxicity, which can affect the host. Specifically, this can lead to toxicity in the kidneys, in the ear, and in the nerves. So nephrotoxicity is a big issue with aminoglycosides, and in general nephrotoxicity is considered somewhat reversible, and it is dose dependent. So the higher the dose, the longer we use aminoglycosides and the more frequently we use it throughout the day, increases the risk of nephrotoxicity. And between the three agents that we use, amikacin, gentamicin, tobramycin, the rate is somewhat similar, but higher than streptomycin. So streptomycin is less nephrotoxic. Risk factors for nephrotoxicity includes increased age, pre-existing renal disease, use of diuretics, exposure to radiographic contrast, circulating volume depletion, and use of other nephrotoxic medications, including ACE inhibitors, NSAIDs, amphotericin, or cisplatin. Next, we have autotoxicity, and we can think of autotoxicity in two subcategories. So one is vestibular toxicity and one in cochlear toxicity. So vestibular toxicity essentially leads to dizziness, ataxia, and nystagmus, and especially with IV or parenteral use, patients typically develop acute bilateral vestibular loss, and these patients will be unable to stand unaided. And these are essentially considered permanent because of the apoptosis of the hair cells in the ear, in the vestibular and cochlear, is essentially irreversible. Now, vestibular toxicity is more with streptomycin than gentamicin and tobramycin, and it has not been reported with amikacin. So now cochlear toxicity is what leads to tinnitus and hearing loss, and amikacin does have this toxicity. So amikacin and tobramycin can lead to cochlear toxicity, but rarely gentamicin. So gentamicin and streptomycin mostly cause vestibular toxicity as opposed to cochlear toxicity. Now, there are some genetic component to this, so there are certain pharmacogenomic characteristics that essentially makes certain patients more susceptible to these toxicities. Now, lastly, we have neuromuscular blockade, which is very rare, and this is essentially happening with amikacin, gentamicin, and tobramycin. And fortunately, muscular blockade can be reversed by administration of IV calcium. And lastly, there are situations where we use a single dose of aminoglycosides, and it's good to know how safe a single dose is. So, for example, sometimes we can use a single dose to treat gonorrhea. We can use a single dose to treat cystitis due to resistant organisms, and for prophylaxis prior to surgery or invasive procedures. And a systematic review of 36 studies, which included 11 randomized controlled trials, showed that a single dose of gentamicin, it can have an effect on renal function, but it's really considered mild and transient. So it's really not considered nephrotoxic in the sense that it will damage the kidneys. And there were no cases of autotoxicity associated with just a single dose of aminoglycoside. So, just a single dose is pretty safe. And, especially when we're waiting for susceptibility results to come back, it is okay to use aminoglycosides empirically, but we should streamline and switch to better options as soon as possible. Now let's take a look at aminoglycoside allergic reactions. In general, allergic reactions to aminoglycosides are extremely rare. In fact, no allergic reactions to plazomicin, which is the newest aminoglycosides that came to the market in 2018, has been reported. Most reported reactions occurred in children or patients over 55 years of age, so most patients will not have any allergic reactions to aminoglycosides. And the most frequently reported type of allergic reactions are cutaneous, so things like allergic dermatitis, contact sensitivity, ulcerative dermatitis, urticaria, rash. And there could occasionally be some serious cutaneous reaction like tan and dress. And anaphylaxis has been reported from parenteral use. When it comes to aminoglycoside allergies, it's helpful to think of aminoglycosides in two main structural classes. So streptidine, which is only streptomycin in this group, and the rest of aminoglycosides, some of which are not listed here, belong to deoxystreptamine group. So those are structurally similar, whereas streptomycin is structurally unique. And what we have found is that cross-reactivity among aminoglycosides with deoxystreptamine group is at least 50%, and therefore all streptamine aminoglycosides are contraindicated in patients with hypersensitivity to another deoxystreptamine aminoglycosides. Whereas cross-reactivity between deoxystreptamine aminoglycosides and streptomycin has not been observed. So because streptomycin toxicity, in general, we don't use streptomycin except for patients that really need an aminoglycosides and they have an allergy to one of the aminoglycosides. For those patients, streptomycin is an option. We estimated creatinine clearance. We looked at the mechanism of action and toxicodynamic properties of aminoglycosides. Now, the next learning objective is describe the pharmacokinetics and pharmacodynamics of aminoglycosides. Let's review what pharmacokinetics means. Traditionally, pharmacokinetics is known as what the body does to the drug. It basically involves ADME, absorption, distribution, metabolism, and elimination. It's important to consider absorption so we know the bioavailability of drugs. When it comes to distribution, it's important to know protein binding. So for example, some patients may have low albumin. Albumin is the #1 protein that binds antibiotics. When it comes to metabolism, it is important to know if specifically a drug is metabolized with the CYP enzyme. That could include drug interactions. And of course, when it comes to elimination, it's important to consider renal, biliary, and fecal clearance. Now, when we say clinical pharmacokinetics, we basically mean application of these pharmacokinetic principles to safe and effective therapeutic management of drugs in individual patients. And the goal is enhancing efficacy while decreasing toxicity. What about pharmacodynamics? Pharmacodynamics is actually what the drug does to the body. In the case of antimicrobials, the body refers to the pathogen. So we don't really want the drug to do anything to the human body. So once a drug is given to a patient, the body will handle the drug. So there will be absorption, distribution, and elimination. So this is the pharmacokinetic properties. And then there will be concentration in the body fluids and also at the site of infection. And then at the site of infection is when you want the drug to do something to the pathogens. And that will be the pharmacodynamic outcomes, which we refer to as PK/PD. And of course, there are things that antibiotics do to the body, and those are referred to as toxicodynamics. These are the things that we don't really want antibiotics to do to the body. Here are some important parameters to know. On the horizontal axis, we're looking at time, and on the vertical axis, we're looking at concentration of drug. So once a drug is given, at the end of infusion, you get the maximum concentration, and that's referred to as peak or Cmax. And then once we stop the infusion, the body starts to clear it. So the concentration goes down until it's time for the next dose. At that time, we have the minimum concentration or trough, also referred to as Cmin. And then the next dose is given and the drug goes up. And then at the end of infusion, the body starts to clear. There's also the concept of area under the curve, which is all the shaded area here, for a 24-hour period. So it doesn't matter how frequently you give the dose, the AUC is often from time 0 to 24 hours. So if this drug was given once a day, you would only have one of these over 24 hours. Also, if this drug was given every 8 hours, then you would have 3 of these peaks. But regardless, AUC is the area under the curve for a 24-hour period. And of course, you could get the level at any time between peak and trough, and that would be considered a random level. Now, when it comes to antibiotic, these things only tell you how the body is handling the drug. So whether it's AUC or the peak or the trough, it's basically telling you how much drug is left in the body at a specific time. It doesn't necessarily tell you anything about the pharmacodynamics of the drug, because it doesn't really tell you anything about the organism, and we need to know something about the organism. And what we need to know about the organism is the MIC, or the minimum inhibitory concentration. We can combine these pharmacokinetic parameters with MIC to get PK/PD indices. So the three commonly used are the peak to MIC ratio, the AUC to MIC ratio, or the time above MIC. So when the concentration goes above this MIC concentration, it will go above and then eventually will go down and then go below the MIC. The time it takes to go above the MIC and then below the MIC, that's referred to as time above MIC. Bioavailability of aminoglycosides is negligible. Basically, less than 5% is absorbed. Therefore, majority of aminoglycosides are IV formulations. So the oral formulation are typically not available because not enough of it is absorbed for systemic infection. So when we do use oral aminoglycosides, because it is not absorbed, it's primarily for a GI purposes. For most patients, the volume of distribution of aminoglycosides are 0.25 liters per kilogram, and we will use these numbers when we get to the calculations portion of this topic. Aminoglycosides are primarily excreted renally, and the half-life is about 2 hours in someone with normal renal function. However, in someone with renal impairment, the half-life could be between 50 to 70 hours. In this picture, on the horizontal axis, we're looking at time, and the units of time are hour, and on the vertical axis, we're looking at the log drop in the CFU, or colony forming units of bacterial growth. So CFUs are basically units of measuring how much bacteria grow on culture. So in all three of these experiments, we have the control. So the red circles are control, meaning that if we don't use any antibiotics, we just let the organism grow. So as time goes on, bacteria grow in the absence of antibiotics. Now the question is, if we start to introduce antibiotics, how much does it prevent growth of bacteria? MIC is the minimum inhibitory concentration of a specific antibiotic for a specific organism. So in these experiments, we're giving antibiotics in increasing concentration and see how much increasing the concentration affect the growth. So for example, on the left hand side, we're looking at the antibiotic tobramycin. So if we give a quarter of the MIC, as time goes on, you can see that the growth of bacteria slows down but doesn't completely prohibit it. Now if we gave exactly at MIC concentration, as you can see that as the time goes on, bacteria start to die. So the colony forming units start to drop. Now at higher concentration, so for example at 4 MICs, you can see that bacterial growth actually drops faster, and as we increase the concentration, this drop in growth of bacteria becomes larger and larger. This suggests that tobramycin has concentration dependent killing, meaning that the more of a concentration of tobramycin that we use, the more the growth of this organism was dropped. Now let's look at ciprofloxacin. Ciprofloxacin, they did the same experiment. So you can see that as they increase the concentration of ciprofloxacin, more and more of the organism died as time went on. Now compare that to ticarcillin, which is a beta-lactam. Now as they increase the concentration of this beta-lactam, you can see that the organism dropped, but at some point, increasing the concentration didn't make a difference anymore. So for example, once we reach a concentration 4 times the MIC, we got the maximum amount of killing. So 16 times the MIC in negligible amounts. In fact, a concentration 24 times the MIC made no difference compared to 16 times MIC. And this suggests that beta-lactams do not have concentration dependent killing, whereas tobramycin, which is an aminoglycoside, and ciprofloxacin, which is a fluoroquinolone, these two show concentration dependent killing because at the highest concentration of these antibiotics resulted in the most amount of killing. So generally speaking, antibiotics can be divided into concentration dependent and concentration independent killing. Now we're looking at the evolution of PK/PD. So as time went on, then clinicians started to refer to concentration dependent as time dependent. So we had concentration dependent and then we had time dependent. And as I showed you the examples of fluoroquinolones and aminoglycosides, those are concentration dependent. And then the time dependent would be the beta-lactams as well as vancomycin. And the PK/PD parameter for time dependent, specifically for beta-lactam, is the time above MIC. So it's not necessarily the concentration of beta-lactams, it's more of how long the concentration is above the MIC that would result in maximum killing of organisms. Now compare that to concentration dependent. So if you have a high concentration, the ratio of peak concentration to MIC, the higher this concentration will result to the maximum amount of killing. And then there's the concept of AUC, or area under the curve to MIC ratio, which is used for aminoglycosides and fluoroquinolones, which I will explain more. But this AUC to MIC is also used for vancomycin. So generally speaking, peak to MIC ratio is used for concentration dependent, and time above MIC is used for time dependent. And then AUC to MIC, it just depends. For some antibiotics, AUC to MIC means concentration dependent, and for some antibiotics such as vancomycin, it just means time dependent. In this picture, we're looking at the concentration time curve. So on the horizontal axis, we're looking at time, and on the vertical axis, we're looking at concentration. The time above MIC, which is used for time-dependent antibiotics, primarily beta-lactams, is the pharmacodynamic parameters for beta-lactams. And we like to target the time above MIC of 40 to 60% of the dosing interval. Now, the ratio of peak to MIC is used for concentration-dependent antibiotics such as aminoglycoside. So our goal is to have a peak to MIC to be 8 to 10 times the MIC. So we want the peak to be 8 to 10 times the MIC. So if the MIC happens to be 1, we want the peak to be 8 to 10. So 10, for example. Whereas if the MIC happens to be 2, then you want the peak to be 20. So 10 times 2 would be 20. And then we have the concept of AUC to MIC, which we will talk about more when we talk about vancomycin. And AUC to MIC is primarily used for vancomycin, as that's basically the area under the curve. So it would be all of this area. This would be the AUC. Now, another thing that's specific for aminoglycoside is the concept of post-antibiotic effect. Post-antibiotic effect means that when the concentration went above the MIC, the antibiotic starts to kill. And then once the concentration goes below the MIC, the antibiotic continues to kill for some period of time. So as you can see from here to here, the aminoglycoside continues to kill. And that's referred to post-antibiotic effect. Now, here are some PK/PD targets for commonly used antibiotics. So for aminoglycosides, the best PK/PD target is AUC to MIC, specifically for non-critically ill patients is 30 to 50, and for critically ill patients is 80 to 100. However, doing AUC to MIC at bedside is not practical, so most clinicians actually do the peak to MIC, because you can easily get the peak level, and once you have the MIC, you can actually see if it's 10 times the MIC. So for the purpose of this class, we're going to do the peak to MIC for our monitoring of aminoglycosides. And we have another day dedicated to vancomycin calculations, which we will discuss at that time. We looked at mechanism of action and PK/PD of aminoglycosides. Now the next learning objective is, given a patient with a suspected gram-negative infection, determine a traditional empiric aminoglycoside maintenance dose and frequency based on population kinetics. Once you assess patient's body weight and creatinine clearance, the next step is to calculate population volume of distribution. And by population, we mean that these numbers are derived from population studies. So these are actually an estimate of what it would be in your patient. Because aminoglycosides are hydrophilic, they distribute primarily in the extracellular fluid. So fluid status is extremely important. In someone with normal fluid status, so in a general population, the estimated volume of distribution is about 0.25 liters per kilogram. Now, if someone is dehydrated, this volume of distribution will be reduced. So for the purpose of this class, we're going to use the number 0.15 liters per kilogram. On the other hand, if someone is overhydrated, the volume of distribution will be increased. So we're going to use 0.35 liters per kilogram in this class. Of course, some reasons for fluid overload is heart failure, peritonitis, edema, ascites in patients with cirrhosis, pregnancy, and cystic fibrosis. You will learn about cirrhosis and ascites in your GI course. Now, of course, because these numbers are liters per kilogram, you have to make sure that you use the right number. So generally speaking, for a normal person, we're going to use ideal body weight. If someone weighs less than their ideal body weight, you should use their actual body weight, which will be the smaller number. And in obese patient, we're going to use adjusted body weight. By now, you know that the PK/PD target for aminoglycosides are peak to MIC ratios and AUC to MIC ratios. For simplicity, we are only going to look at peak to MIC ratios in this class. So the target for peak for severe infections is 8 to 10. For moderate to mild infections is 6 to 8. For urinary tract infections is 4 to 6. And of course, if you use aminoglycoside for synergy in gram-positive organisms, the peak will be 3 to 5. Now, the peak is what tells you the efficacy. So the peak to MIC ratio should be these targets, and that tells you efficacy. We also target trough for safety. So we want to make sure that the trough is also less than 2 for all of these to make sure that we minimize the risk of nephrotoxicity and ototoxicity. Now, the dosing for tobramycin and gentamicin are identical. So these targets are for both gentamicin and tobramycin. Now, if you happen to be using amikacin, so these are the different targets for amikacin. So once you figure out what you want to target for your patient, next we need to actually calculate elimination constant before we can come up with the dose and frequency. So again, this is an estimate from population. So it's not going to be exactly the same K in your patient, but empirically estimation is the best thing we can do. So this is the equation we're going to use, which includes creatinine clearance, and that will give you the K for your patient. And once you get your K, you will use this equation to get tau. Tau is frequency. So this is going to tell you how frequently should you give the dose to your patient. And this is based on how the patient is actually able to clear it. So you basically plug in peak and trough goals. So if this is a severe infection, for peak, you're going to write 10. And then for your trough, you're going to write, let's say 1. So you want it to be less than 2. And then you plug in the K and you solve for tau, and that tau will give you will tell you how frequently you want to dose it. And of course, then we want to round the tau to something realistic. Frequency should be every 24 hours, every 12 hours, every 8 hours, every 6 hours. So those are things that are regular. So you don't want to do something like every 5 hours or every 7 hours. That's going to make the schedule hard to follow, and it's going to make it very difficult for the nurses to administer the drug. So you want to use standardized frequency. So if you get a tau of 5, for example, you want to round it to the closest standard frequency, which would be 6. So once you figure out the tau, after you round it to something realistic, then you're going to use this equation to come up with a dose. So let's say if you found the tau of 5 and rounded it to 6, so you're going to use 6 in this equation. You use the K that you got from up here. You put the target peak that you want. You put the volume of distribution from previous slides and the K again. And here you put the time of infusion. So for simplicity, we're gonna infuse aminoglycosides over 1 hour. So you just plug in 1 here. It is also common to use 30-minute infusion. If you were to use 30-minute infusion, you just have to put 0.5 here, which makes calculations more difficult. It doesn't matter whether you do 30-minute infusion or 1 hour infusion, as long as you get the dose right and the frequency. So I recommend that for making calculations more simple, just use the time of infusion of 1. And when it comes to monitoring, we want to monitor both trough and peak. So the trough, you want to get it within 30 minutes of prior to the 3rd dose. So that's as close as it gets to steady state. So you want to get the level before it gets to, or actually close to the steady state. And then assuming that the level is at goal, you would just want to get the trough every 3 to 5 in most patients with stable renal function. Of course, more frequent monitoring would be required depending on the clinical status and also on renal status. Trough monitoring is for safety, and we do peak monitoring for efficacy. So the peak you want to do at least 30 minutes after the end of the infusion to allow distribution to the tissues. And of course, it's also important to monitor serum creatinine due to nephrotoxicity of aminoglycoside. So in stable renal function, at minimum every 3 days. In someone with unstable renal function, you want to monitor daily. We use Cockcroft-Gault equation for creatinine clearance. We explained pharmacology and PK/PD of aminoglycosides. We also use population kinetics to come up with traditional empiric aminoglycoside dose and frequency. Now, the next learning objective is given the patient with a suspected gram-negative infection, determine a high dose extended interval once daily empiric aminoglycoside maintenance dose based on population kinetics. In the previous objective, we looked at traditional dosing of aminoglycoside. So this purple line shows you a classic traditional dosing of aminoglycoside. So we typically want to have a peak of 10. Now a peak of 10 would be good only if the MIC happens to be 1. So 10 to 1 ratio. If the MIC happens to be 2, then suddenly 10 is not good enough. You need a peak of 20 in order to get the peak to MIC ratio of 10. So 20 divided by 2 would be 10. Now this causes an issue because while the peak tells you efficacy, the trough tells you toxicity. So it doesn't matter how high you go, you gotta let it go below the trough of 2 because you don't want to cause toxicity, specifically nephrotoxicity and ototoxicity. So in traditional dosing every 8 hours, you're hoping that the peak was not too high and it would allow time for the trough to be less than 2. Now, when you look at these purple lines, you can see that the majority of the time, the levels are actually in the toxic range. So it's only a very short period of time that the kidneys get a break. So this causes an issue for safety. Also keep in mind that aminoglycoside have post-antibiotic effect, meaning that once the level goes below the MIC, the antibiotic continues to kill for up to 7 or 8 hours. So we can actually take advantage of that. So that led to the concept of once daily high dose extended interval dosing. So basically the red line shows that if you give a very, very high dose of aminoglycoside, you're gonna get a very large peak and that gives you efficacy. So, when you have a very large peak, you for sure you're gonna have your efficacy. And then because you only do it once a day, that's gonna give you 24 hours for the levels to drop and then go below the toxic range. And then because of the post-antibiotic effect, it's okay to wait until the next day to give the next dose. So not only will this increase efficacy because of the higher peak that's possible now, but also reduces toxicity. When it comes to extended interval dosing of aminoglycoside, there are different ways to do it. One way is to actually use equations to calculate dosing and you set your tau to 24 hours. There are also nomograms that are established for the use of aminoglycoside. Now, when you use a nomogram, it's important to make sure you use it in patients that the nomogram has been validated. One in particular is the Hartford nomogram. So the Hartford nomogram should be avoided in pediatric patient, in patient with acute renal insufficiency, or if the creatinine class is less than 20 or the patient is on dialysis and has end-stage renal disease. It should not be used for mycobacterial infections, and it should not be used in patients with altered volume of distribution, such as patients with ascites, cirrhosis, pregnancy, severe burns, and hemodynamic instability. And it should not be used for gram-positive synergy. So for gram-positive synergy, you should always use traditional dosing. So the way it works is that you basically initially you use a dose of 7 mg per kilogram for gentamicin or tobramycin, and you use almost twice as much for amikacin, so 15 mg per kilo. And then for a normal renal function, this is once a day dosing. However, if the patient has renal insufficiency, so for example, creatinine class of 40 to 59, then you set the frequency to every 36 hours, and 20 to 39, you set the frequency to every 48 hours. And of course, creatinine clearance less than 20, this nomogram is not recommended. And the way that you would monitor is that you actually get the random level. Instead of a peak and a trough, you get a random level between 6 to 14 hours after the start of the first dose. And then you adjust the dose based on that level. And here's the nomogram. So this nomogram on the left is for gentamicin and tobramycin, and the one on the right is for amikacin. So let's say 9 hours later you got a random level, and the level happens to be 3, and it happens to be here. If you were using the Q24 hours, that means the patient is clearing, so you continue the Q24 hour dosing. Now, if for that very same patient, 9 hours later, you got the level that was 7, because 7 falls above this line of Q24, but it's within the Q36 dosing, so 9 and 7 goes here. Instead of continuing the dose every 24 hours, you change it to every 36 hours. The same would be true if, if you 9 hours later, you got the level that's, let's say 9, so 9 and 9, you would change the frequency to every 48 hours, and so on and so forth. So that's how you would monitor. And the way this was established is that Nicolaou and colleagues actually tried this dose in their patients, and they got the peak of 20 because the most common MIC in their institution was 2, so they wanted a peak of 20 with the MIC of 2, which would give you a peak to MIC ratio of 10. And then they just looked at how quickly the patients were clearing the aminoglycosides, and that's how they derived these lines. We looked at creatinine clearance, we looked at pharmacology and PK/PD of aminoglycosides. We also looked at traditional and extended interval empiric dosing of aminoglycosides. Now, the last learning objective is, given a patient with a gram-negative infection, select an individualized aminoglycoside dose and frequency based on serum aminoglycoside levels. Aminoglycosides follow first-order kinetics, also known as linear kinetics. And the reason this is called linear kinetics is because if you plot the natural log of aminoglycoside plasma concentration on the vertical axis and time on the horizontal axis, then you can actually get a linear relationship between two levels. This is assuming that the two levels are after the infusion and after the distribution phase. When you first start the infusion, the levels go up very quickly till the infusion is stopped. At this point, the concentration is at peak level, followed by a rapid drop in concentration for two reasons. One, the kidney starts to clear the drug, and two, the drug is also distributing into tissue throughout the body. This is known as the distribution phase. Once the distribution phase is over, meaning that all tissue is filled with the drug, then the levels drop at a slow rate because it is now only due to clearance by the kidneys. And it's during this phase that we would like to get levels to calculate the slope of the line, which would give us the elimination constant, or negative K. You can use the famous equation C equals C naught times e to the negative KT. And basically means that your final concentration equals your initial concentration times e to the negative KT. And the T is the time between the initial concentration and the final concentration. Another way of saying this is that C2 equals C1 times e to the negative KT. It's just a matter of how you label it. You can adjust the dose based on the measured peak and trough, or the two levels that you have, by calculating a patient-specific K. And the way that you calculate the patient-specific K is by rearranging that equation to solve for K. So imagine that your first level is here after the distribution phase, and we're going to get that level at time 1, and then you get the second concentration later during that same dosing interval, and that will be at time 2, and then the time that it takes between the two concentration would be the delta T. Or in other words, is T2 minus T1 will be delta T. And that is the T that goes into this equation. Now keep in mind that the first level, C1, it has to be at least 30 minutes after the end of infusion, because at the end of infusion you have your actual peak. But if you actually measure the peak at the end of your infusion, then you end up with the wrong slope. Because, for example, if you use this as your peak and then with the C2 concentration and you calculate the slope, you can see that the slope is very different. So it would falsely give the notion that the body is clearing the aminoglycoside very quickly. Similarly, if you measure the peak and use it with C1, you're going to get a very steep slope, which would give you a false notion that the body is clearing aminoglycoside very quickly, which is not true. So it's very important to get your levels at least 30 minutes after the end of infusion to make sure that it's outside of the distribution phase. Now, what's different about this K as opposed to the K that we calculated previously is that previously we used population data to estimate the K, so that's not very specific to the patient. But now, because we have two levels from the patient, this K is specific to the patient. So we call this individualized pharmacokinetics as opposed to population-based kinetics. Of course, if C1 and C2 are not true peak and trough, you can actually extrapolate. So you can say the equation is peak equals trough times e to the kt, or another way of saying it is trough equals peak times e to the negative kt. Again, these are all the same equation. It's just a matter of rearranging them to get what you're looking for. And of course, what you do with the K is to get the individualized volume of distribution. So the volume of distribution that we calculated previously was an estimate. But this time, since we have a specific K from the patient, we can actually calculate the actual volume of distribution in the patient. And what we do with the next is to calculate tau again. So now instead of the estimated K, we use the actual K that we calculated in the patient. So get the new tau. And then using the new tau and using the individualized K and the individualized volume of distribution, now we come up with a dose that's very accurate in the patient. Once we get the dose and tau, then we can actually verify to see if it's gonna give us, if the new dose and frequency is gonna give us the peak and trough that we want. So we can actually use this to estimate what peak we can expect from this dose and frequency. So you plug it in and it will tell you what the peak is, and then you use this peak here to see what trough it would give you. And that's how you verify to see if the dose and frequency that you're about to recommend is actually gonna give you to the goal peak and trough. We will do exercises in class to do some calculations. This concludes this presentation.